Welcome again, everyone, to today's panel on healthcare decision-making and planning for the future. I'm Dina Schwartz, and I am the Director of New York State Guardianship Initiatives at Project Guardianship. We are very excited to present this panel to you. Project Guardianship, it was founded in 2005 as a program of the Vera Institute of Justice to fill this sort of gap that left unprotected a population of largely low-income aging adults and people living with disabilities and mental illness who lack family and other supports. And since then, Project Guardianship has been serving this population as a court-appointed guardian. And we have a multidisciplinary team of case managers, financial managers, and attorneys that specialize in keeping people in their homes and out of institutions, and when possible, restoring their rights. And we also do research, provide education, advocate for better policies and practices. So this panel came about after our Good Guardianship and Autonomy Preservation Coalition had its kickoff event in the fall, and we asked for, what do people want to learn? What do people have a lot of questions about? And this topic came up. So we put together this wonderful panel, and you all had some great questions. Thanks for submitting them in advance. As mentioned earlier, we're going to be keeping you muted, but you can ask by raising your hand to be unmuted to ask a question. We are going to be having 3 brief presentations from our panelists. If there's any clarifying questions about their subject matter, we can definitely have those questions be asked right after they're done with their presentations, but we have plenty of time, at least 20 minutes at the end, dedicated just to your questions. So before we go to the panelists, I'm just going to do a quick poll so that we can know a little bit more profession-wise who's in the room. So I'm going to launch it now and just give everyone a few moments. So also our panelists know who the audience is.
Dina, I don't see mom/dad on that panel.
Other. If you don't feel represented in the poll, definitely feel free to pop it in the chat. All right, I'm going to give 10 more seconds. It's already 11:07. All right, ending the poll. So you can see we have a lot of case managers and social workers, guardians, people from legal services, but also a couple of folks from community-based organizations and government. We have well represented by a lot of different groups, so that's great. APS, yes, that is right. It is impossible to check more than one box. I'm sure a lot of people identify with many of these categories. All right, so I am going to turn it over to the panelists to introduce themselves, and then we will get started with the presentations. So let's start with Heather. I see that you're unmuted already, so let's start with Heather, okay, and then Diane and Alyssa.
Do you want me to just go right into my presentation?
Oh, no, just everyone can introduce themselves briefly, and then we'll go into your presentation.
Okay, so hi, I'm Heather Deere-West. I am an attorney and the Director of Civil Legal Services with the Rural Law Center of New York. The Rural Law Center of New York is a not-for-profit where we offer free legal services and consultations to low-income New Yorkers who reside in any of the 44 rural counties of New York.
Diane?
My name's Diane Meyer. I'm a physician, geriatrician, and palliative medicine doctor, and former director of the Center to Advance Palliative Care, a national organization that tries to improve access to palliative care, and many of the populations we serve either have or need guardianship.
Great. Alyssa.
Hi, everyone. I'm Alyssa. I'm a social worker at New York Presbyterian Cornell. I help manage and serve as the lead social worker for our Vulnerable Elder Protection Team, or VEPT for short. And I'll briefly go into what that is when I present, and also help Dr. Tony Rosen, for those of you who might know him, with a lot of research pertaining to elder mistreatment.
Great.
And I'm really happy to be here. Thank you.
So we're going to turn it over to Heather to get us started with the legal background here.
Hello, everyone. So again, Heather West. I'm going to try and cram my usual 1 hour presentation into 8 to 10 minutes. So, good luck to me. For how I usually typically approach this is if you all were my clients sitting across from me in my office asking me what should I do about advanced healthcare directives. There are lots of variations of things, and I think it gets confusing for a lot of folks. And I'm really just going to concentrate on two in particular, the Healthcare Proxy and then the Family Healthcare Decisions Act. But there are such things as living wills. In New York, we have a living will, and then we have a last will and testament. I have lots of clients who get those confused. A living will is very similar to a healthcare proxy, but not quite. In that living wills tell physicians, your family, what your wishes are in particular situations regarding your healthcare. And it typically does not name an agent. That's the person who can make some decisions on your behalf. We also have things like DNRs and DNIs, do not resuscitate, do not intubate. Those are medical orders, and those are done with your physician. There is also, depending on your situation, if you are facing a terminal illness, your doctor may suggest filling out a MOLST form, a medical order for life-sustaining treatment. Those are always visibly hot pink. And I believe we had sent you out one of these forms. These are forms that you do fill out with your physician or a physician's assistant or a nurse practitioner, my apologies. And these can include, obviously, do not resuscitate, do not intubate, no CPR, the withholding of artificial nutrition, hydration. But again, these are things very medically oriented in terms of who you would do these with. For me, I always advise my clients to have, let's start with the healthcare proxy. So the healthcare proxy is a pretty simple form, and you can find the form, and the one we use on the New York State Department of Health website, and I believe it's also the form that I forwarded to Dina to show all of you. It pains me to say this, but you don't need an attorney to do this. You don't need a lawyer to fill out the healthcare proxy. It should be your choice. You can discuss it with your family, you can discuss it with your doctor. I always do discuss it with my clients, even though they don't need me to fill it out for them. But I always want my clients to make sure that if the worst thing happens, you are prepared. So for a healthcare proxy, you, as the client, as the patient, are going to appoint someone, and it's one person at a time, to act as your agent. And that agent is there to make medical decisions for you based on your wishes, desires, morals, and beliefs when you no longer can make those decisions for yourself, when you lack capacity. If you have capacity, despite whatever your medical condition is, your decisions, your medical decisions are always yours. But there are some situations, and we don't like to think about it, but it will occur. It does occur every day, where we may no longer be able to speak for ourselves. And so who do we want to speak for us in medical situations? Typically, we turn to family or spouses first. And of course, that is totally acceptable. Keeping in mind, it has to be one person at a time. So if you have 3 children, you cannot name all 3 children at once, but you can name them sort of in a successor order. A, then B, and if not A or B, then C, that's allowed. But sometimes those closest to us may not be the right person to be the agent. And I do explain this to my clients all the time. When we're talking about literal life and death situations, we also have to remember the person making the decision, are they capable of making that decision and living with that decision? My one example for that is I had a friend whose father had cancer, and it was a terminal illness. And she's the one who made the final decisions about treatments and what to do and what not to do. And I can remember after he passed, she said to me, because at the same time my mother was sick, I don't know if I did the right thing. Did I do the right thing? Because for her, her emotions were so closely tied to her father, even though she knew what he wanted, she still wasn't sure because it was just too much for her. And that's a horrible burden to put on somebody. So even though typically we do turn to our loved ones, we also have to take a step back and ask ourselves, are they the best person for this particular situation? If they are, fine, that's perfectly fine. But if not, it's okay to name somebody else. It may be difficult, and sometimes people don't want to hurt somebody else's feelings, but this isn't about somebody else. This is about your choice and who you want to speak for you. And those decisions, as I said, can include, life and death. Do you want certain medical treatments? Do you not want certain medical treatments? Do you want something tried, nothing tried? Do you want something in between? Because remember, at that point, you're not going to be able to speak to yourself. You need to be able to rely on the person you choose. So I highly encourage everyone to take a step back and make sure that the person you choose is the person for the job. And obviously, also speak to that person about this. They may not want the job. They may not want that burden. In and of itself, as I said, the form is pretty simple. You fill out the name of the person with their address and phone number. Name an alternate. I always ask you to name an alternate because, again, if something happens, we're not going to be able to fix it after the fact. And then you need to sign it before 2 witnesses. Now, those witnesses need to be 18 years old and older, and they need not be whoever you named as the agent. It can't be the agent. And that's it. You can also, if you want, elect to be an organ donor on the form. That's up to you. Again, you would sign on a separate line and date it. But yes, it can be that simple. But I do see where clients have done this themselves and they've named, like I said, the multiple people, or their agent has also acted as a witness. Those are pretty common errors. So if we want to skip that part and just do the 2 separate witnesses and sign it, it should be fine. You can also add, and I do this all the time, a supplemental page to the healthcare proxy. So there is a section there on the form. I'll show you here. On paragraph 4, it says optional. If there are specific things you want to add to your healthcare proxy, and there's only 2 lines here, feel free to put, please see supplemental page and add separate instructions, and just make sure I always staple it to these forms. And I would also have the client sign that form with 2 witness signatures on the supplemental page and have that attached to it. Sometimes I'll have folks with living wills, and we can also say, please refer to a living will for certain situations. I think that's perfectly acceptable. A living will can offer guidance. My choice, my preference is always going to be a healthcare proxy, simply because you've got an agent, and healthcare proxies tend to be very broad if you leave the language kind of open. Whereas, like I said, living wills tend to be very specific and don't have an agent, but they do offer evidence, I think. So I know I've already been chatting a lot, so we're going to wrap up the healthcare proxy part, and we're going to talk about the Family Healthcare Decisions Act. So what happens if you don't have a healthcare proxy? That you totally ignored my advice and said, no, I'm going to wing it. Well, then New York does have the Family Healthcare Decisions Act. And what that is it's a statute that tells the medical facility who can make medical decisions for you if you haven't named an agent. And while in some aspects it's good, because at least there's something, it is not perfect by any means. And I'll show you why in a second. So there's a hierarchy of who can make medical decisions for you. So depending on your situation, if you have what's called an Article 81 guardian, they're the first person. If you don't have that guardian, then it's going to go down the line to a spouse or a domestic partner. If you don't have that, then we're going to hit children. Now, if you have one child, that's fine. But again, with this, only one person's allowed to make these decisions. And if you have multiple people at certain levels, there could be conflict. And that conflict can cause delay. And that's where I see the Family Healthcare Decisions Act kind of tangling itself up. Again, so even after you have children, there are other, parents, siblings, and then close friend. Any level I say beyond spouse is a potential for conflict. And as I said, that conflict is going to cause delay in whether you receive treatment or don't receive treatment. There's going to have to be a process as to determine who or what should occur next, who's going to be the spokesperson for you. And there can be varying and wildly differing views of what you want. And again, let's not forget, we're throwing in the emotions of the event. And sometimes it may not be the person you want. Say we're at the level where it's your siblings choosing for you, and you have that one brother who you can't stand, but he's the one that's stepping up. Is that the person you want to make that choice for you? So if not, that's where I always kind of steer my clients to, let's make a healthcare proxy for you. In the Family Healthcare Decisions Act, the process I just described, the Article 81 guardian, the spouse, domestic partner, children, then the varying lines. That's for adults who have had capacity, but just simply didn't name an agent. There are other structures in place should the patient actually be someone who is what they call a 17 or mentally or intellectually disabled individual who have 17A guardians appointed for them. So there's another level of guardians stepping up first. If there's no guardian, then they're going to go to family members. But if there are no family members, then it comes down to possibly the, and I know somebody was wondering about Willowbrook, and there's an advisory committee. They are on the same level as a family member, qualified family member. Beyond that, then there's the surrogate decision-making committee. There are structures in place because unlike people who have had chance to think about what they want to happen, sometimes our disabled patients were never had that chance, or were never had thought about or had the ability to think about these kinds of treatments and what they want. So there are other procedures in place under the Family Healthcare Decisions Act. And, my apologies for being so broad and general about this, but again, I only have a short amount of time. But I do want you to know it is out there. The last thing I'm going to say in terms of all of this is I press the need for a healthcare proxy because you don't know what's going to happen. Things happen out of the blue. So when somebody says who should have a healthcare proxy, I say everybody. Everybody should have a healthcare proxy. Here's my story. As a good daughter, I made my mother have a healthcare proxy. It's a conversation we had all the time. And one day on Friday night, she went to bed with a headache, which is not unusual. In my family, we all suffer from migraines. Didn't think much of it. Saturday morning, she woke up. We thought she had the flu. She wasn't acting right. She had a terrible headache. I went out and got her ginger ale and crackers, because that's what you do when you're English, as my mother was, and tea. When I got back, her eyes were listing to the left. Off to the ER we go. Keeping in mind, I had a conversation with my mother Friday night. She seemed fine. She just had a headache. Saturday morning, we find out she has a brain tumor and it's terminal cancer. I had to make decisions very quickly. And because I'd had these conversations with her, and because we had a healthcare proxy in place, and my brother and sister knew what was going to happen and knew what my mother's wishes were, in a horrible, horrible situation, it was, strangely enough, the best case scenario, because that's what you want to happen. You want all of these things in place. So when you are going through a horrible time, you don't have to think about, am I doing the right thing? You know, what does that person want? I knew. And strangely enough, it did make things easier. And I don't tell the sad story for sympathy. I tell you this so that you understand how quickly things can change and how hard these things can be if you're not prepared. So again, for my point, I always want my clients to have a healthcare proxy. I always push them to have conversations with their families or friends. You know, they can have these conversations with your friends. This isn't a Christmas morning conversation, but it is a conversation you need to have. And you need to have it more than once because things happen, things change. And again, I don't think of this as being morbid. I think of this as being prepared and helping your family know, and without a doubt know, what should happen for you. So I'm pretty sure I've gone over my allotted time. My apologies, Dina. But I'm going to wrap that part up, and I'm looking forward to your questions.
Thank you so much, Heather. I'm glad that we had give you a little bit more time to share your story, because I know you've told me about that as well. And, you know, thanks for being willing to share that. And it really illustrates how important this is. There were a couple of questions during yours, but I'm going to save those during the Q&A session at the end, because they're kind of good for everyone. And I'm going to turn it over to Alyssa.
Thanks, Heather. I'm going to share my slides. Just bear with me for a moment. See. All right. Can everyone see? Good. Okay.
Yep.
So as I said, I'm Alyssa, and I primarily work for the Vulnerable Elder Protection Team, which is a hospital-based multidisciplinary team that's available 24/7 to assess cases of elder mistreatment. And we're comprised of social workers, doctors, physicians assistants, nurse practitioners, and we hope to increase identification and reporting of elder abuse while decreasing the burden on busy providers, because these cases require a lot of time, a lot of resources that, you know, busy ER and hospital providers don't have time to address. And we are modeled after child protection teams, which are available in most hospitals, so people are familiar with this type of system. So now to get into what we're really here for. Managing healthcare decisions when patients cannot make their own. We, of course, defer to any existing documentation. And as Heather said, if there's no designated healthcare proxy, which we always try to encourage people to have a healthcare proxy when they're in the hospital. If we know they don't have one, we always offer to help facilitate that, because if not, we have to go by the Family Healthcare Decisions Act. And in the absence of a healthcare provider or any kinds of surrogate, you know, if someone's really isolated and doesn't really have anybody around, we will engage hospital patient services, legal, and ethics teams who will almost always advise to preserve life. That's kind of what the default is. There's one or two exceptions, but that's generally what we're advised to do. So you want to make sure you have somebody who's going to make medical decisions that are aligned with what you would want. So what if the abuser or the healthcare proxy or surrogate is the abuser? Again, patient services and ethics are always notified. And you might be surprised to know that 99% of the time, they're going to advise us to continue to work with the abuser on medical and discharge decisions unless they begin to make decisions that don't seem in the patient's best interest. And if there is a disagreement, for non-urgent matters, the hospital legal and patient services are going to encourage us to try to get the healthcare proxy abuser to kind of agree with what we're saying. We spend a lot of time meeting with them, trying to validate, their experience, but working really hard to get the healthcare proxy to understand where the medical team is coming from and make a decision that we feel like is best. If it's an urgent decision that needs to be made and we're kind of at a head, escalation to patient services and legal is going to be required. I'm going to kind of illustrate this with a brief case example that I actually had experience with a couple of months ago. Ms. A was a 93-year-old female with dementia who came to the emergency department from a nursing home with a chief complaint of hip fracture. The nursing home staff said she had been complaining of hip pain, but there was no known fall. And because of her dementia, though she was verbal, she wasn't able to provide a story of, why she was in pain or what happened. So our VEPS program was consulted due to concern for the hip fracture of unknown origin, as well as bruising to her left wrist. And orthopedics was consulted and determined that she required surgery. However, we saw in her medical chart that she had advanced directives stating she did not wish to be hospitalized under any circumstances. And on top of that, this was, as these things always are, it was like 10:30 at night, and her distant relative, who was her designated healthcare proxy, was unreachable. So what did we do? Our program, VEPT, recommended that the team reach out to the administrator on call or AOC for guidance. That's basically patient services after hours and is the liaison to legal. And they advised that we admit the patient for safety given the unclear etiology of her injuries, as well as the inability to reach her healthcare proxy. In the morning, we did make contact with him, and he was actually in agreement with hospitalization and thought that the patient would want admission and medical intervention if it would improve or restore her quality of life despite her advanced directives. So we did that day perform surgery, and that surgery was that so she could be able to continue to ambulate rather than being bedbound for the rest of her life. And simultaneously, our program was evaluating the abuse concerns, and we interviewed several people at the nursing home, spoke in depth with the healthcare proxy and with the orthopedics team. And after our investigation, we felt that our concern for abuse was low, and that given she has dementia and is quite ambulatory, and unfortunately nursing home supervision is not probably what it should be, it was likely that her injuries could have easily been sustained from an unwitnessed fall. And that's it. Mine was very quick, but I really look forward to talking with you guys and answering any questions you might have. And let me stop sharing.
Thank you, Alyssa, and thanks for sharing that story. I love all the stories that all the panelists are sharing. It helps really put all this into context. We definitely got a couple of questions in advance that you might be able to help answer, and we'll just save that for the Q&A section, which hopefully we should have about 20 minutes for. And I'm going to turn it over to Diane. Just bear with us for a moment while we get the slides set up.
Can you hear me?
Yeah, I can hear you. Do you want me to share?
Let me just try one more time. Can you see my screen?
Yes, we can see.
Okay, great. Sorry, everybody. So as I said before, what they said, so I will be very brief and essentially reiterate much of what you've heard. And so I'm speaking from the standpoint of the clinician in the emergency department or on the floors or in the clinic who's confronted with the patient who cannot make their own medical decisions. And I'll tell you what actually happens in the clinical setting. Decisions are not made in advance. So just as you learned from the case you just heard about, this patient said she never wanted to be hospitalized under any circumstances. Now, perhaps she didn't anticipate that the circumstance might be a broken hip that could be fixed so that she could walk again. So what happened? Her wishes were overridden because the current reality, the specifics of the situation made that decision not very sensible, since there was a procedure that could be done that would restore her level of function and improve her quality of life. So bottom line is decisions are actually made in real time. They are not made in advance. And no matter how much your client is clear and insistent about what they would want in the future, decisions are almost always revisited and made in the light of the reality of the current situation. Because frankly, just as with the patient we just heard about, it's impossible to anticipate the specifics of the future medical situation, and decisions are in real time and should be based on specifics. I'll give an example of many of my patients who have documents, living wills, MOLSTs, other forms of what are called treatment directives that say, I would never, ever want to be on a ventilator under any circumstances. And then we have that same person admitted to the hospital with community-acquired pneumonia and transient difficulty oxygenating, in whom we believe that a short period of intubation while receiving IV antibiotics could very well restore this person to their baseline health. Do we honor the advance directive that they would never, ever want to be on a ventilator? Or do we correctly assume that they didn't anticipate the possibility that they might need it just for a few days, and that in return for that burden, they had a really good chance of recovery back to baseline? Most of the time, we don't pay attention to the advance directive because the specifics of the situation are ones that we don't think the patient anticipated in making that decision. So obviously, and everyone has said this, and I'll reinforce it, the most important thing to do is to appoint another person your client trusts to make decisions on their behalf. Because both in the hospital and in court, the appointed healthcare agent has the same authority as the patient, him or herself, would, to make decisions. They're guided by either knowledge of the patient's wishes, values, moral position, past decisions, past life priorities, or what they believe is in the patient's best interest. And usually that decision is made in collaboration with the clinician. So for example, a healthcare proxy might say, well, what she said she never wanted to be hospitalized, or she said she never wanted to be on a ventilator. And then there's a conversation that occurs with the clinician who says, in return for hospitalization, we hope this patient's hip fracture can be fixed and she can go back to being able to move around on her own as opposed to being bedbound. Very often the healthcare proxy will agree that that is in the best interest of the patient. Same thing with the short-term use of a ventilator in a pneumonia situation. In general, I advise patients and families not to bother with a living will because they cannot possibly anticipate the specifics of the future situation. And the acceptability of treatments is contingent on the likelihood of recovery. People imagine that a ventilator or hospitalization is a one-way street. into machine dependence or death, but very often that's not true. Very often people get better and can go home and go back to an acceptable level of function. So understanding the likelihood of recovery is essential to making specific medical decisions. The single exception to this rule that I review with all my patients and families, just as I talk about seatbelts and bicycle helmets and vaccinations and nutrition and exercise, is I ask my patients to think about what they would want if there was no chance of recovery enough to recognize and interact with people. So this is what I say. Some of my patients or clients say they would want care focused on making sure they were comfortable if they were permanently unresponsive, like in a coma. Others of my clients say they would want to continue all life-prolonging treatments, no matter what their mental condition. Which kind of person are you? This is the only specific circumstance that is very low likelihood of recovery to consciousness and ability to recognize and interact with other people, where an advance directive on treatment is valuable and will be followed. So the summary of my remarks are decisions are made in real time based on the specifics of the actual situation in the clinical real world. Therefore, appoint someone you or your client trusts to speak on your behalf in real time for times when you cannot decide for yourself. And tell that person what you would want if you were permanently unresponsive. Care focused on keeping you comfortable versus continuing to prolong your life. And that's really the most important information that I wish more people knew. And I'll stop talking now and stop sharing.
Thank you, Diane. I'm gonna unpin you. All right, so we have about 20 minutes for questions, which is great because we have a lot of questions. Oh great, the panelists all have their cameras on. If all panelists can have their cameras on. So we did get one question, Diane, just now while you were talking, asking if someone is guardian, do they have the same decision-making role as a healthcare proxy? Are there any differences? Who wants to take that?
I would defer that to Heather.
Could you repeat that, please? I'm sorry.
If someone is a guardian, do they have the same decision-making role as a healthcare proxy? Are there any differences?
They do. Probably the only difference I would say is knowledge. That the guardian has to know, based on the patient's moral, religious backgrounds, what their decisions would be regarding withdrawing artificial nutrition and hydration. That's almost like a separate arena when it comes to medical treatments. So there's like routine things and other treatments, and then there's withholding artificial nutrition and hydration. So with the guardian, they have to have pretty much specific knowledge as to what that person would want or what's in their best interest. They also have to take into account what the medical condition is, likelihood of recovery, basically what Diane said. So there are some other factors that take that into account, but a guardian can make those decisions. I think just to clarify, when I'm talking about guardian in this particular conversation, I'm talking about a 17A guardian. So there are a couple of guardianships under New York law. There's a guardian for a minor child. That's in Article 17. There's a guardianship for mentally or intellectually disabled individuals. That's the 17B. But a lot of times you'll also see an Article 81 guardianship. And Article 81 guardianships tend to be for older individuals who are now suffering from a debilitating illness such as Alzheimer's or dementia, something that affects their ability to, or their capacity to make medical decisions. So it's that's a whole different realm. So in this context, though, we are talking about 17B guardians.
All right, we have a ton of questions rolling in. There are a couple of people who asked sort of similar questions about if there are these documents, what do providers do to make sure that they find out whether or not these documents exist? That seems like a big issue. Are they mandated to look? How does that work?
So I'll speak from what I know. Medical people are required to inquire about whether somebody has advanced directives. That is set forth in the statute. However, I also recommend to my clients that if you have a healthcare proxy, give a copy to your doctor, give a copy to the hospital, give a copy to everybody you want under the sun. I don't care who it is, but make sure they know that you have these advanced directives. Because otherwise the doctors can only go on, they can't make medical decisions, that you may know, or gosh, I'm mixing this up here. They are required to provide treatment that you may not want if it sustains your life. So you've got to tell your physicians, you've got to tell your medical staff you have these directives.
Yeah.
And I would just add to that just because the law says we're required to do it has very little impact on what actually happens in the chaos of the real world.
Absolutely.
But in theory, somebody asks, is your daughter who's visiting you every day your healthcare proxy? And may or may not be. And so we run it, or there may not be one, and the patient may no longer have capacity to appoint someone. So it is not, you should not assume that somebody else is taking care of it.
Yeah.
As Heather's point, you've got to speak up and say, I'm the healthcare proxy, or I know my dad appointed my sister as the healthcare proxy.
I'm sorry, just to say that if you are the healthcare proxy and you're in the hospital medical situation, have a copy of that healthcare proxy with you and show it to the physicians and give it to the physicians. When my mother was sick, I had that copy on me at all times because there were varying doctors and visits, and I handed that thing out like it was money. It's like, here's a copy for your records. Yeah, it's one of those documents that you don't have to hold to yourself. Give it away.
Do any of you recommend, let's say someone has a MOLST? We had one person mention that they feel when someone is being particularly transferred to maybe a skilled nursing facility setting that it just gets lost in the process, or they're told that that facility needs their own MOLST, or they didn't get a hard copy, etc. Does anyone here want to talk about what happens there? Any suggestions how to stop that? Any suggestions for people who are dealing with that?
Well, I think
Heather.
Diane probably has more real life experience than what I see on, in black and white on the books. But a MOLST form travels with the patient. And it should be easy to find because that's why it's hot pink. That's why it is that particular color, so it stands out. It could be reviewed when a patient transfers to another facility, but I don't believe that it has to be redone when it goes to a new facility.
So I think the question is more, in theory, that's what's supposed to be done, but other people's experiences are that's not what they feel is actually happening.
Yeah, and I turn it over to Diane.
Yeah, it doesn't actually happen. Again, not because of malfeasance or evil intent, just the chaos of getting people out of the hospital. And there's no paper chart anymore, Heather. It's all electronic, and the MOLST exists as an e-MOLST, and the healthcare proxy is scanned into the medical record, and the nursing home does not have access to the medical record. And this notion that somehow this discharge nurse is going to take the time to find the forms on the electronic health record, copy them, attach them to the discharge, it just doesn't happen. So what that means is that who's ever advocating for the patient once they arrive at the nursing home, whether it's one of you guys or a family member, has to be responsible for that. You just have to remember that it's chaos out there. Everyone's doing the best they can with way too few resources and way too little time.
I think the good news about
So
it,
the advocacy has to be on the patient and the patients who care about, people who care about the patient, unfortunately.
yeah, the good news about everything being electronic is, like, for example, in the case I discussed, we saw all of her documentation in the chart. It was uploaded from her last hospitalization or whenever she was here and provided those forms. So even though she had dementia and couldn't, wouldn't have been able to tell us who her healthcare proxy was, it was all right there. And kudos to the team for checking that the appropriate tab in the electronic medical record. But the good news is that hopefully once you bring those documents to the hospital, they will be uploaded, and the team should check, but you should also always have physical copies. And if a MOLST is done at the hospital, you should ask for a copy so that when the discharge happens, you can show it at your next stop.
And that's what I mean, that the MOLST is supposed to travel with the client, with the patient. It's not staying in that direct, the medical record should travel. And I totally agree with Diane. I mean, like I said, I can tell you what's on black and white on paper, but the reality is, the hospitals are super busy, we don't have resources, and things can get lost in the shuffle. Absolutely, it happens. It certainly can happen. And again, that's why I also encourage my clients, make sure everybody in the world has a copy. Bring your stuff with you. And you're right, advocate.
So speaking of MOLST forms, we have questions about the actual filling out of these forms and what the role of a social worker may be in filling them out.
They actually are medical orders.
Okay.
So there actually are orders that EMTs have to follow in the field, theoretically, that nursing homes have to follow. So they have to be signed by either a physician or DO or a physician assistant or a nurse practitioner. However, the counseling part of it, which is time consuming and nuanced, very often should and could involve a social worker, because the form is confusing, I would say, at best. It's confusing for physicians. It's confusing for patients and families. And often what's on the form has to be modified by handwritten things. So for the same thing, we just went through this with a family of a 92-year-old with mild to moderate cognitive impairment, and they don't want her to get the usual full court press. On the other hand, we had to say to them, what if a treatment could be short-term and return her to her current level of function? Oh, well, in that case, we would want it, right? And the MOLST doesn't allow for that. And so we wrote that in on that if recovery is considered likely to prior level of function, yes, I want hospitalization. Yes, I want intubation. Yes, I want artificial nutrition. If recovery is unlikely, and I am not likely to recover to be able to whatever the level of function the patient says is acceptable, then I don't want these things. And that is not part of the MOLST. And that's the problem, because it turns into a binary black and white decision, things that are contingent on the exact circumstance that the form doesn't include. So, so they're tricky. They're very tricky, most forms.
Diane, I heard you. Oh, go ahead, Heather.
Oh, no, I was just about to say, when it comes to forms, that's why I always prefer a healthcare proxy, say, versus a living will. Living wills tend to be very, very specific. And if your condition isn't met by that specific one you've put in the living will,
it doesn't apply.
It doesn't apply. I will say, and in part, and I think I'd seen a question about this, for living wills, they can be offered as, in my terms, evidence to what a person's, ideas or beliefs or anything like that. I think it's good for that, but it wouldn't be the thing I would rely on for my care. I want a healthcare proxy, and I want that proxy as broad as possible.
Exactly.
So Diane, we got a couple of questions related to artificial nutrition. The questions were related to what is the role of a healthcare proxy when deciding whether that artificial nutrition should be terminated, and just if there's not evidence of a person's wishes in general and maybe nobody is around, how does that go?
Well, so the first question is, does the proxy have the authority to start and stop artificial nutrition and hydration? The answer is yes. The proxy has the same authority the patient would. And it's the same as a decision to start a ventilator or not. It's a medical intervention like any other medical intervention. And every medical intervention has benefits and risks. And those benefits and risks have to be weighed in the context of the current situation. So again, I personally would want a feeding tube if I could have it for short term while I'm, say, recovering from a surgery and I can't eat. But I wouldn't want it necessarily permanently to keep me alive in a vegetative state. None of these forms allow for that level of nuance, right? But the healthcare proxy, because they are me in the eyes of the law, can have the conversations with the clinicians and say, is this going to be permanent? Or do we expect her to recover to be able to eat and drink again, since that is her greatest pleasure in life? And that's how decisions are made in real time, or should be made in real time. Based on the current reality. And yes, the proxy has the authority. If there is no proxy and we end up with the Family Medical Decisions Act, Heather, correct me if I'm wrong, I believe the standard is clear and convincing evidence for artificial nutrition and hydration, meaning the patient explicitly said or wrote that they would never want artificial nutrition and hydration. So in the absence of a proxy, the standard of evidence is much higher for a decision to withhold artificial nutrition and hydration. Another reason for getting the damn healthcare proxy done. So you are not in a stranglehold of legal restriction, basically.
Right.
Thank you.
And the level, the clear and convincing, that's the highest you can go. And it should be that high because we are talking about life and death. So again, I cannot agree with Diane any more than saying, get that healthcare proxy done. Get it. And again, like I said, as much as I hate to admit it, you don't need a lawyer to do it.
No, you
very
don't.
antithesis of my little soul, but.
So I'm going to try to squeeze in a couple more questions because we're going to end up with some unanswered, lots of questions. So in terms of decision making, a great question. Do clinicians generally view consent to place or consent to discharge as the same as having the capacity to make medical decisions? Like, can a healthcare proxy or someone under the Family Healthcare Decisions Act make decisions for someone to go to a nursing home or be discharged for rehab?
Yes.
Yes.
Mm-hmm.
Great. Well, that's good to know, because that's always a big issue. Sometimes people end up with guardians because they just need someone to say yes or no to that. So
Yeah.
I like a clear yes to a question. I'm going to switch gears a little bit. We got 3 minutes. Are there any documents anyone recommends that would be different for people who have a domestic partner or LGBTQ individuals to make sure that people in their lives can obtain death certificates?
Okay, so that's a little different. So healthcare proxy, and just as an aside, power of attorney end upon death. If you want someone to have access to a death certificate, name them as your executor in your last will and testament, which is a totally different subject that I could go on for hours about. Because as the executor, you are entitled to getting copies for the death certificate because you got to probate the will. Also, if you are what's called a direct beneficiary, under, say, a life insurance policy, you are entitled to get a copy of the death certificate. And there is also, and it sounds strange, and I have done this for a few clients, and I just want to make sure I get the name right. You can pre-plan your funeral so that you can say, this is the person in charge of my remains, and they are entitled to get death certificates. There is a form from New York State Department of Health called an appointment of agent to control disposition of remains. It's this little form here. And this is the form that you can fill out that says, this is the person that's going to be in charge of my remains and be in charge of my funeral and what happens. I would do that. I've done that for couples just to make sure, because, you know, there are families who may not like that situation. We'll put it that
Right.
way.
So again, the bottom line is critically important to appoint a healthcare proxy, because that person has real power and authority, as if they were a mother, a father, or a sibling, or anyone else that the patient appointed. But that
that's what
ends
relationship
in
is.
death. It ends in death. So the person also has to be appointed, as Heather said, the executor of the estate, and complete that advance decision about who has control over the remains. Then the LGBTQ partner has access to the copies of the death certificate. So there's a sort of triple preparation, not both during life and after death, that has to.
And I recommend this for any partnership, because one of the key things here is, in this particular kind of situation, is, and I can't stress this enough, grief does weird things to people. And those relationships that you thought were absolutely fabulous turn to dust when somebody is grieving. And any kind of old resentments and hurt feelings, they always show up after death. So even if the family member got along with the partner, when a person dies, that may blow up. So have it in writing. You have to have it in writing. Put it in a will, put it in an appointment, put it, you know, make plans ahead of time. You know, I think people tend not to want to do this because, first of all, none of us want to admit we're going to be sick. None of us ever want to admit that we may never be able to control, you know, have complete control over our lives. And apparently we're all going to live forever, right? For that one person in 1,000 trillion million, good for you. But the rest of us have to face reality. And I think being prepared is the one thing you can do. I don't think of it as morbid. I think of it as a way to take care of the people I love when I'm no longer here. There's my lecture on getting prepared.
That's a good way to end. I see that it's 12:01, so we're over time. I know that there were some questions that didn't get answered. I'm going to go through and collect them and see if there's any way that at least the ones that are maybe not giant and theoretical that really deserve a long discussion can get answered, but we'll try to get as many of them answered as possible. I am putting a very brief evaluation form in the chat. It's also a place where you can let us know what sort of information you're interested in learning in the future, what you think we should be prioritizing. You know, this one happened because of you all. So please let me know. Reach out if you have any other feedback. And thank you so much for coming. And thanks to our really, really wonderful panelists. I learned a ton, and everyone go make a healthcare proxy. Get a healthcare proxy. Everyone get a healthcare proxy. Yeah.
Thank
So,
you.
and I don't know, Dina, if you want to, but feel free to give out my contact information if anybody else has any questions.
Okay, great.
Yep.
Thank you.
Me too.
Thanks.
Thank you, everyone. Have a great rest
Thanks
of your
again,
week.
Dina. Bye.
Bye.
Bye.